Okay, and I'm happy to welcome everybody to another episode of Machine Medicine's Neuromodulation Past and Future interview series. And we have the great pleasure today of having Dr. Georgios Matis from Cologne, who is a neurosurgeon there, who has taken an interest in neuromodulation in particular as it's applied to peripheral vascular disease. Although I know you have a more general interest in pain and other phenomena like that. Georgios, thank you very much for taking the time to talk to us. And perhaps you'd be so kind as to give us a brief introduction as to yourself and your background, how you got into this very interesting area.
I would be glad to. Thanks for having me. Hi, everybody. Thanks for joining us. So my name is Georgios Matis. I'm coming from Greece. You can hear that. I'm a neurosurgeon. I finished my residency in Thessaloniki, a small town in the northern part of Greece. And then I spent 6 months in the Weill Cornell Medical College in New York in a skull-based lab as a research fellow. After that, I spent 12 months in the University Hospital of Zurich in Switzerland. I got a scholarship there in the Department of Neuroradiology. Back then, I was really interested in treating aneurysms with stents and such things. And after finishing this scholarship, I discovered neuromodulation. It was a pure coincidence. I met in Thessaloniki my mentor, Dr. Koulouzakis, he's still a big name in the field of neuromodulation. He was looking for help back then. I didn't know anything about neuromodulation. I didn't speak German. I had to learn German as well. But I did it. I tried to learn German. I came to Germany and learned how to do all of these surgeries. And now, since 2018, I have the honor to lead the pain and spasticity section in the Department of Stereotactic and Functional Neurosurgery in the University Hospital of Cologne. My main focus are patients with chronic pain and spasticity.
Fascinating. It's so interesting to hear, Georgios. And another brilliant peripatetic Greek, spreading learning and the medical benefits as he goes. I wonder which was more difficult, learning the neurosurgery or learning German, but that was
learning German.
I bet. Fantastic. And Georgios, and there's a particular area of neuromodulation that we're keen to focus on, just because it's such a vast field nowadays. So we always try and focus on one particular area that's usually a special interest of our guest. And would you say a little bit? I mean, one of the things about neuromodulation that we find so fascinating is the number of different and surprising applications that it continues to have. We've had guests on here that have, of course, talked about, what you might call conventional neuromodulation, things like deep brain stimulation and movement disorders. Okay, that kind of makes sense and maybe it's intuitive. But we've also had guests on here talking about tibial nerve stimulation for urge incontinence and even for sleep apnea, neuromodulation for sleep apnea, another very surprising but apparently well evidenced and an effective form of it. And one of your particular interests is in the use of neuromodulation for treating peripheral vascular disease. So would you said that prima facie that sounds perhaps implausible to some people. How do you go about using neuromodulation to treat peripheral vascular disease, and why does it work? You might say a little bit about what peripheral vascular disease is to start with, for those of us that don't know.
Let me start from the very beginning, because I'm sure there are people watching us who never heard of the term neuromodulation. I could tell you to visit the official site of the International Neuromodulation Society, neuromodulation.com. There you can find many definitions of diseases and therapies, but we can simply say that neuromodulation is the electrical impulses, or chemical with drugs, modification of the nervous system. And this leads to a different response of the nervous system to a stimulus or to a pathological condition. In this context of neuromodulation, we have many options, many therapies. I'm particularly interested in the intrathecal therapies, the pump therapy, and the spinal cord stimulation therapies. Now, in the spinal cord stimulation, just for those who never heard of it, we are trying to implant 1 or 2 leads orally, so near the spinal cord, apply electrical impulses, and modify the function of the nervous system. There are many indications for this therapy, mainly patients with failed back surgery syndrome or persistent spinal pain syndrome. This is the new term now. Patients that have already been operated on the spine and they still have pain. Patients with complex regional pain syndrome. Patients with vascular disease. And this is what you are mentioning. I assume you read an article in the British Journal of Neurosurgery, or read an article there. But there are also patients with angina pectoris or polyneuropathies and many other indications. To answer your questions, peripheral vascular disease, this is a huge problem worldwide. I did some research, I looked at the statistics. Worldwide, there are approximately 200 million people with peripheral vascular disease. In the United States, 7 million. And with a prevalence only in the United States of as high as 30% in older populations. So it's a huge number of patients that could be treated with spinal cord stimulation. And just to speak the same language, peripheral vascular disease or peripheral arterial disease is simply the narrowing of the arteries. All or most of the patients have atherosclerosis, so they have lipids in their vessels. And as mentioned, risk factors are considered smoking, hypertension, diabetes, and dyslipidemia. So it's a common condition in the population, and many of our patients are really undertreated.
And I dare say it's something that's increasing as a problem, is it, with the obesity epidemic?
It's the style of living, the way we are living. But this is the first problem. The second problem comes from the medical community, because we know there are many therapeutic options for such patients. For example, drugs. This is the first step. It's acceptable. There are some revascularization procedures, for example, percutaneous angioplasty or bypass grafting. All these are acceptable therapeutic options, but we should never forget that we have also this neuromodulation option that could really help patients. And what is always surprising to me and fascinating is that all of these symptoms that these patients are having are really underreported or not reported at all. Why? Because the patients themselves and the families of the patients are thinking that these symptoms are only a normal part of the aging process.
So what are we talking about? Is this like the pain, or?
Most of them have a feeling of tiredness, heaviness, of pain in the lower legs mainly. They cannot sleep well, poor quality of sleep because of the pain. They have swollen legs, they cannot walk big distances, and many of them have sores or wounds that are not healing. In the
Got you. And so, what are the advantages? Because a question we always, of course, everyone always asks when a new therapeutic is developed or proposed is, well, why do we need it? What are the shortcomings of current therapeutic options? Why do we need a neuromodulatory approach?
Let me answer this question a little bit different. It's not about a new therapy. The therapy is there for more than 50 years. The first clinical application
Stimulation
was in 1967 in the United States.
Yeah.
And the first, let's say, experiments for vascular diseases was in 1901. There was a colleague back then, Bayliss, I think it was in the United Kingdom, who stimulated the dorsal roots of animals and just watched which areas of the skin would exhibit this flashing. So actually, he was working on dermatomes. And then we had in Germany in 1933, difficult times back then, a colleague, Förster, who experimented on medical students. He stimulated the peripheral nerves of medical just to see if he could get this vasodilation. And only in 1976 was the first clinical application of spinal cord stimulation in patients with peripheral vascular disease. And we have many experimental work on this as well. So it's not a therapy, it's an old problem, it's an old therapy, but we don't get many patients referred to us, and we can help them. What are the advantages now of this therapy? As I mentioned, of course, we should start with drugs. Of course, we should try with stents or bypasses, but there are patients who are not satisfied after all these options. They still have pain. There are also patients with major comorbidities who are not allowed to be operated, to have big operations, big surgeries. These are good candidates for spinal cord stimulation. And one more important thing, we are speaking about peripheral vascular disease or critical limb ischemia, which is the advanced stage of peripheral vascular disease. And we're always thinking about pain. Pain in the area of the vessels of the leg. And we also forget that after an amputation in this area, the patients could exhibit a phantom limb pain.
Yeah.
In the area which does not exist. And this is 50 to 80% of the amputees. It's not a small percentage. Or you can have stump pain after an amputation. Spinal cord stimulation can help for these things as well. And the main advantages are that the therapy is reversible. It's not a destructive procedure. We don't destroy anything. We only stimulate something. We make a cut in the skin, a puncture in the spinal canal, and we implant a lead. If it doesn't work, we can simply remove the lead without damaging any muscles, any nerves, or other things.
Gotcha.
These are a big advantage. We are not working with drugs in this therapy. We are working with electrical impulses, which is also a plus because we all know drugs could have potential adverse effects. We can have liver problems, kidney problems, and so on. And the main thing for me as a neurosurgeon is that I have a therapy for various problems at the same time. I can treat the pain of the peripheral vascular disease. I have a therapy there if an amputation takes place for phantom pain or stump pain. And it's not only about pain, it's about improving the circulation in the limbs, the blood flow in the limbs.
Great. Yeah, so let's talk about that. So that's important, right? Because it's not just, as you say, it's not just the pain that you're treating. This is not just taking a well-established pain therapy and applying it to a group of patients that happen to have pain for underlying, but you're actually mechanistically intervening in the vasculature, right? So how does that work, and what aspect of the disease is it helping with?
This is a very nice question. There are tons of articles out there on animals, on patients. There are many mechanisms of action. I could tell you some of them. You all know this gate control theory since 1965 that states very quickly that a non-painful input, the alpha-beta fibers, could close this gate to painful inputs from alpha, delta, or C fibers. We don't really know if with spinal cord stimulation, if we reduce the excitation of the wide dynamic range neurons in the dorsal horn, or maybe we increase the inhibition of the wide dynamic range neurons, or maybe both of them. We do know we have inhibitory pathways, descending pathways that are acting at the level of the spinal cord. We do know that we have an inhibition of the sympathetic system with this nicotinic transmission at ganglionic and post-ganglionic junction. We also know that we have a release of opioids, beta-endorphin, metenkephalin, or vasoactive compounds, such as vasoactive intestinal polypeptide, or calcitonin gene-related peptides, substance P, endothelium-derived relaxing factor, nitric oxide, prostaglandins, and many, many other possible mechanisms. But it works as long as the patients are being referred to us in a good stage. We have at least two classification systems for these patients. We have a Fontaine classification with 4 stages. The third stage is pain at rest, and fourth stage, pain at rest plus ulcers. And we have also the Rutherford classification. It's not that important, but the important thing is that the vascular surgeons who are usually seeing these patients should start thinking about the option of spinal cord stimulation when the patients are in the second B stage or in the third stage. Then the results are really good.
Let's back up a little bit, because one of the mechanisms that you mentioned was the reduction of sympathetic drive. And if I understand correctly, is that the proposed mechanism for a putative improvement in the perfusion of the tissues that are affected by occlusion of arterial flow?
Exactly, and this is true also for patients with angina pectoris. In these two patient groups, angina pectoris and peripheral vascular disease, the mechanism of action is assumed to be the same, a reduce of the tone of the sympathetic system. And there are publications stating that if the patient has less pain, this pain reduction could lead to less activation of the sympathetic system as well.
I see. So yeah, that could be a dual kind of action.
Exactly.
Direct reduction of sympathetic drive, and then also indirect through the elimination of pain. Very interesting. And of course, these blood vessels are often relatively large and innervated, actually directly innervated with sympathetic fibers. Is that right? So the wiring diagram makes sense for this, right?
It makes sense, and this is why colleagues have also tried to do different sympathetic blocks. But the main problem is if you do it on both sides, it could lead to even more problems for the patients. This is why the blocks for these patients are not the optimal treatment option. And this is why we're trying to raise awareness about the spinal cord stimulation, because we don't have any extra additional problems when we apply this therapy. The main problem is now that if you look at our publication in the British Journal of Neurosurgery in 2021, you will see that we incorporated 6 RCTs, randomized controlled studies, 1 Cochrane review, and 1 meta-analysis. But these randomized controlled trials are dated back to 1994 till 2000. So 20 years ago was the last randomized controlled trial, and all of them were performed using the classical tonic stimulation, a stimulation with a tingling feeling.
Yeah, which causes paresthesia, and therefore there's no proper blinding, which is something you mentioned in your paper as an issue. But one that's now with new stimulation new stimulation protocols like burst stimulation, we can indeed now do properly blinded randomized controlled trials. Is that your contention?
The scope of writing the article is to draw the attention of the colleagues to spinal cord stimulation once again for this therapy, and simply underline the fact that all the results that we are having are all of them based on this tonic stimulation. Now we have new stimulation paradigms, new waveforms, subperception with tingling. You mentioned burst. We have also burst-like. We have other subperception waveforms. And it would be very interesting to see what will happen if we apply these waveforms or a combination of them. You can apply now 2 different waveforms at the same time in the same patient. For example, tonic stimulation and burst at the same time. In the same patient. Or if we could apply these waveforms sequentially for some hours tonic stimulation, for some hours subperception stimulation, and just see what is going to happen. In this way, we can do double-blinded studies now because the patient does not feel any tingling with subperception waveforms, and we can be sure what if the patient is telling the truth. This is also a problem in studies. But we can also conduct some controlled RCTs. That in many patients, even if you don't activate the system, there is a pain relief.
Of course.
In peripheral vascular disease patients, it's a little bit different because you can see also, for example, the color of the skin when the therapy is working. For me, it would be also very interesting to see how we can combine now the spinal cord stimulation therapy with other neuromodulation options. For example, at the same time, spinal cord stimulation and dorsal root ganglion stimulation, or spinal cord stimulation and at the same time peripheral stimulation.
And what would be the benefit there? Why would that be just a kind of double whammy, kind of double dose of neuromodulation, or is there some sort of non-linear interaction?
You're targeting different neural structures.
Got
If you are stimulating the peripheral nerves, you're stimulating the third order neuron. When you're using spinal cord stimulation, you're stimulating the second order neuron. Maybe if you stimulate at the same time both of them, maybe the effect would be much better.
Or maybe you cancel out the effect of the stimulus. Could you?
Or it could be much worse. This is also an option.
So but it does raise this interesting question that we get across neuromodulation: is this kind of combinatorial explosion of possibilities, right? It's not like, I mean, with a drug is essentially a static asset, right? You give it is what it is. It's licensed for what it's licensed for. You give it to the patient. You can vary a couple of parameters, really just the dose. Okay, maybe you can change the times that people, but you're talking like a fairly low dimensional parameter space. Whereas with neuromodulation, we immediately get in, or seems fairly immediately get into these very high dimensional combinatorial explosions. And so what does programming look like in this context with these kind of patients? Is there a kind of feedback loop of adjusting parameters, and is it as complex, or is it simpler?
It's not simpler. Programming is science, but programming is also an art. It takes many years of experience to be able to program these things. It becomes even more difficult because now we have many more options and many more softwares that are really complicated.
Yeah,
we have maybe too many options now, but still we have patients who are not satisfied with these options. So getting back to the definition of neuromodulation, we can, using leads or drugs intrathecally, we can influence all neural targets. So in principally, we can treat, theoretically at least, all diseases where the nervous system is involved. So most of the diseases. So the indications, there is no limit for these indications. This is why I love neuromodulation. It's an evolving field. Every 6 months, at the latest, we have something new, not only in the spinal cord stimulation thing, but also in all other options. We have vagus nerve stimulation, for example. It's a very good therapy. Now actually only for depression and epilepsy, but it could be used in the future for autoimmune diseases as well.
Absolutely.
Many other indications. What we really need is something that we can measure objectively. Pain cannot be measured. This is a huge problem. If you have a patient with diabetes, you can measure the glucose level in blood. If you have someone with pain, you must trust the patient. If the patient says, I have pain, he has pain.
Yeah.
Why it would be a very good idea to find a biomarker maybe, which could help us determine if the patient has pain and how strong this pain is. The first step is this closed loop technology that we have now since 4 or 5 years. And this is also fascinating because when we plug the lead, we can not only stimulate the spinal cord, but at the same time, we can measure the reaction of the spinal cord to the stimulation and then adapt the stimulation according to this response, measuring this evokable action potentials or ECAPs. This is one more therapeutic option, and I'm sure all companies that are active in this spinal cord stimulation field are going to use it in the future.
Yeah. So are these evoked potentials? Are you actually using them clinically to program? And you have identified signatures within them that tell you whether or not you're likely to get a therapeutic effect. Is that right?
This is not a science fiction. This is something that we are using everyday practice. We have the technology now. There is one specific company which provides this technology at this point, but we also already have implanted more than 10 patients, at least in my hospital, with this technology, and we can see that the results are really good. And the main idea is, why do we need this closed loop stimulation thing? Because if we don't have it, it is possible that we're going to give even more current, more electrical impulses to the spinal cord, which the spinal cord does not need, or at some point much less. So you have overstimulation or an hypostimulation, and both of them are not good for the patient. When we have the spinal cord stimulation, the closed loop stimulation, the stimulation stays almost 99% of the time within a small therapeutic window, meaning the patient gets the electrical impulses that he needs, not more than that. This is a simple explanation of the technology. It is not related to acupuncture. I see a question here. It's a completely different technique, but we should also mention the disadvantages of this option. It's a fascinating therapy, but it's a surgical procedure, meaning that as major complications could happen in the minority of the patients, not frequently, but the patients should know that who have infections, who have bleeding. If the surgeon is not experienced, you can injure a nerve. And in the long run, you can have dislocation, movement of the leads in the spinal canal. So it's not a therapy where we can say that the risk is zero. There's no zero risk surgery, but the danger is really, really small, especially in experienced hands, in centers with big volumes of operations.
Yeah, I mean, what are the prospects for, this is a lot of people say that, actually the real scalability of neuromodulation lies in non-invasive neuromodulation, and only once we achieve non-invasive approaches to treating these conditions that will neuromodulation's full potential be realized, because then people could essentially receive a device in the post and maybe even use it at home much with little more complexity than, say, taking aspirin or something. But I guess we're some way away from being able to stimulate and record with the same level of fidelity as you can with indwelling devices.
Exactly, you're right. If I were a patient, I would surely choose a non-invasive approach. I wouldn't say, okay, I'm glad to have a surgery.
Yeah.
But at this point, and I think for the next 10 years at least, the implantable systems are the most reliable option. The clinical results are much, much better.
Right. And what do you see as the main rate-limiting step in this area? Is it mainly this issue with clinical research, or is it technological, or what are the if somebody's going to university now and they really want to work in this area and they want to have a big impact, should they become an engineer or a clinician or what, or both?
Or both of them?
A rare breed.
I'm fan of the combination therapy. So this is also a combination. I think the results would be much better if all of us were interested in doing parallel at least two things. So maybe it's not enough to be only a physician. Maybe it's not enough to be only a biomedical engineer. Maybe if you are both of them at the same time, it's much, much better. But you see, it's like the problem with the egg and the chicken. It's about the research thing. Because if we don't get many patients, we cannot have big randomized controlled trials with thousands of patients. This is a prerequisite for many insurance companies. And we don't get these studies, then the insurance companies will not pay for the therapy and we cannot help patients. So it's a difficult situation, but it's also a mentality problem because there are many good indications for this therapy with many publications. And nevertheless, there are colleagues, for example, neurologists, who are not referring patients, although the data are there, the publications are there, the randomized controlled trials are there. So I think the first problem that we'll have to face is to convince somehow our colleagues that this is a viable option. We'll have to convince the insurance companies that it's a cost-effective option if the indication is correct, because if the system stays for at least 3 years in the human body, then we save money as a society. but it's a complicated thing. Unfortunately, neuromodulation is still an exotic thing. As a resident, I never heard anything about neuromodulation. As a medical student, I never heard anything about neuromodulation. I had to come here in Germany to learn something about it. This is why I'm really happy to be today with you, and we can speak about this topic and raise awareness. Thank you very much for this.
No, thank you, Georgios. And it brings us back to the motivation for your article that actually through which we came across you and your work to try and propagate the understanding and awareness of this very, very exciting area. And as you say, still embryonic in many respects, but I guess that we're neither of us
embryonic at the same time.
Yeah,
a baby and an old man at the same time.
All right. Well, thank you so much, Georgios, and we'll look forward to watching your progress with great interest, and perhaps even working with you one day at some point once we expand out into spinal cord stimulation. So, brilliant. Thanks very much for your time.
Thank you very much for having me. Have a nice day. Bye-bye.
You too.
Bye.